I think I need to unmute myself. Welcome to the 9th World Congress of Teledermatology. This is a great opportunity for us to kind of do everything virtual. Though I know we would have had more, more networking if we had probably done this face to face, and I think that would be fantastic. So said that, this is the second session where we were talking about. Can you guys hear me?
Yes.
Yep.
Okay, perfect. So this is the second session where the session is on the dermatology imaging, and this is very close and dear to my heart because this is one of the topics which I suggested. I love dermoscopy. I love any non-invasive imaging which helps our patients and arrive at a diagnosis without cutting into their skin. So of course, we still teach when in doubt, cut it out. But right now, the way I teach my residents is when in doubt, check it out with a dermatoscope or with a confocal microscope. So with that and with new imaging modalities, which are going to be coming up, I will be opening up these sessions for questions and answers. So let me go to the moderator console and see what we have today. Okay. So right now, I think we're still waiting for the questions to kind of stream in. Let us start with Dr. Barry. It was a fantastic. I reviewed your whole lecture, and it's fantastic. We do a lot of those in an asynchronous, what we call as asynchronous store and forward teledermatology, where we kind of have steps to take clinical photographs followed by a dermoscopy photograph. We have not incorporated confocal yet, but that's the goal, where we put in confocal, and that would give a dermatology specialist a full breadth of what he needs to look at before he makes a clinical decision, which becomes more than triage to management. I mean to say, if you saw a confocal image of a basal cell, superficial basal cell, you have chalked out margins. I think Manu would kind of later would talk about it. When you have chalked out margins, all you've got to do is bring him for a one-stop shop where you bring him in, do your margins, you're done. Boom, the patient goes back. There is no chance for somebody to come in, do an excisional biopsy, look for margins. Oh, I still see margins are not free. Bring him back again, do Mohs. And there are countries where there are no Mohs, like there's some people do slow Mohs and things like that. All this non-invasive imaging, I think, is going to change how we're going to interact with our population who have a lot of these non-melanoma skin cancers, and even melanomas for that matter. Do you bring them like within 2 days or within a week or within months? So, let's say you looked at the dermoscopy image and said, okay, this is melanoma in situ. So you don't have to bring them right away. Yep. You can bring them in 2 weeks or 3 weeks. Or if you saw a nodular melanoma, you would say, yes, come back in. We would need to take care of this. So all of this, I think, is such an important thing when we are doing imaging, especially integrating imaging into the telemedicine aspect of it. So with that, the first question is to you, Dr. Barry. Do you have like a teaching module to your GPs or to your primary care physicians? That's what we call them here, because most of this asynchronous store and forward teledermatology is between a provider to a provider, right? So until we have a good a patient-friendly dermoscopy model, it's still now most of it what we are talking is provider to provider, right? So yes. Is there a teaching module which you guys follow? Is there a national mandate or a national standard which you follow in in Ireland?
So interestingly, teledermatology is like many countries around the world. It's very new in Ireland, and we're the first out of the blocks, with what we're doing. And we started off thinking that actually we'll use a primary care physician as the initial provider of our imagery. But what we found that they were actually overwhelmed with the COVID-19 pandemic. And so they just couldn't take the time to take accurate photographs. And kind of one of the things when we were lecturing and talking to our primary care physician colleagues is that this is not point and shoot. And the whole thing about teledermatology, teledermoscopy must be high quality. And that does demand and necessitate a certain time input. So actually we had to pivot because we kind of brought out our service. We're launching initially probably just literally as the pandemic started, and it pushed us back by about 4 months. So we actually only went live then in July of 2020. And what we found that actually rather than the GPs, because we had about 36 or so GPs around Dublin, which is the main area of the population, we're probably about 3 million population in around that area, is that there's very little uptake by our primary care physicians because they were so overloaded. So then we pivoted and we actually rolled out our own teledermatology clinics regionally, where we trained up nurses and advanced nurse practitioners, and we trained them how to take good quality photographs. And then I would run sessions with them saying, this is the level of detail we need. And then it became quite apparent that, some people were good at doing that and some weren't. And so, we got then nurses who basically we get the referral, which is the traditional referral from the GP. They can link in directly to us and we can see them within a very short space of days, have their photographs taken, and then that can be reviewed by a number of physicians around the country. And then we can then forward on those images with an advice plan. So let's say if it is, let's say a melanoma or a BCC or SCC, whatever it is, or if it's medical dermatology, we can forward that on if necessary to a hospital specialist. We have plastic surgeons and maxillofacial surgeons and dermatologists involved. So we found that actually the primary care physicians, unfortunately due to the COVID, were not in a position to facilitate taking the photographs. There was a lot of initial interest, but also, to be honest, because I suppose as in a lot of clinical settings, there's the demand outstrips the supply. So there's a pressure time constraint on them where they found that they could probably earn more money by just seeing ordinary patients through rather than spending that time doing a teledermatology referral. So that's why we had to pivot away from that. And so it's a slight different model to what we'd envisaged would be successful. But that's working very well. And the GPs are actually the primary care physicians are very happy because they can send the referral off. They know that's going to be dealt with. And then it goes to one of our specialist teledermatology clinics.
That's fantastic. Just to follow up on that, do you recommend dermoscopy images for rashes too?
So all of our patients who come through the platform, they all get dermoscopy images. Now, kind of what we've said is that if it's for inflammatory disease, obviously there's a lot less importance with that. We do capture those images though, because I think in time going forward, they may actually be useful as a diagnostic tool in the future as well. So we capture them as a kind of a data capture, but primarily when someone comes to us, they get a number of macroscopic pictures. And let's say if it's a lesional referral, then they get a series of dermatoscopic images of that image, and then we can take several lesions in the one case file. And then similarly, we can take similar photographs of a medical dermatology issue as well. So a person might come in, let's say, with a query mole, a dysplastic mole or whatever, a changing mole, we can do that. And then they can say, well, actually, I've also got this rash on my lower leg and it turns out to be osteototic eczema or whatever. We'll kind of give advice and guidance on both issues.
Awesome. Thank you
Dr.
very much. Sir, did you have a response?
Dr. T, can I make a comment on that?
Yes.
About 3 years ago, I did a preliminary study, using the derm light with the PCPs and primary care providers. And basically, I had no problems teaching them how to take good pictures. They would take a regular image, and then they would take a dermoscopic image. I had no problems doing that. But surprisingly, where I found the problem to be was when we used AI. When we used AI to do this, AIs were not totally 100% good. The results were not good. And what happened was the physician would they would use the AI, then the physician would tell the patient what it was according to AI, and then the images were sent off to some expert readers around the country. And the expert readers had some issues with being on the same page. So there was that confusion to the PCP, and there was also the issue of wrong diagnosis by AI. So there were cases when the physician actually says, you've got this according to AI. Then the physicians, the overread people will come back and say, well, no, we think this, and all of a sudden the PCP is caught, with changing his decision on how to treat the patient. And there's nothing worse than a PCP wanting to look bad because he doesn't want the patient to go back with an unknown situation. So the issue of diagnosing disease was very critical, especially using AI in that group. And I would recommend we've got a little more work to do before we actually use AI in the future.
So yeah, I want to second that. I want to echo that. The reason why I say that is because we're kind of working on a very similar project where we are trying to say, see your dermatologist or go home. So just two options, very binary. If you need to see a dermatologist or you can go home, mean to say it's okay, it's a benign lesion. So we're working on a project like that. I think we will see more data moving forward on AI and teledermoscopy or teledermatology.
The only problem, the only problem with that issue is it takes 3 months to book a dermatologist.
Correct.
And
correct.
it's not right if you've got some lesion that looks really bad. It's not right for the guy to wait 3 months to get an appointment with a dermatologist.
Oh, absolutely understand that. So following that, based on your talk, what's the next and the greatest in dermoscopy imaging, which is going to happen in the next 5 years?
Well, I said basically towards the end, I think that the AI has got to be coming in and help the PCPs make an early decision, but we've got to have a backup system where the AI is not the final say-so. And at this point in time, we still have a lot to learn about it. I think in the dermoscopy systems, we've definitely got a lot more work to do in this technology. I think I showed an image of rotating the polarizer, which allows you to see depth. And once we do that, then all of a sudden, the whole field will open up into a different mode, into 3D imaging of a lesion, which will certainly make it easier to diagnose a disease much easier. And one other thing that I mentioned in my talk was that basically, I don't think it's sufficient just to do non-contact except for triaging. So only way I would do triage, I'm not a physician, so please excuse me. Only way I would recommend doing triaging is if you're just screening regularly. But then in detail, when you look at the details, you're going to have to do contact, non-contact, and several different modes of imaging.
Yeah, I really appreciated that, whatever you want to call it, as a tip or a trick in doing your dermatoscope examination, where you kind of move your faceplate of the dermatoscope in different angles from 0 to 180. You can actually view different images at different angles because of the cross polarization. If I'm right, Nizar, correct me. It was fantastic. I did actually try it, and it does do that. So this is really fantastic. I think people should watch it, and I really like that tip. And like I agree. I think integration of AI into the dermatoscope itself, or where you have like a handheld device which can kind of tells you lights up green or lights up red, whatever. I think would be what we will be seeing in future as we move on. Thank you, Dr. Mulani. Again, this question I think I missed with Dr. Barry. Dr. Barry, is for our audience, for our viewers, is there a way you follow your protocol? Like, is there something which, if somebody wants to start doing teledermoscopy tomorrow, is there a way you would is there a kind of an algorithm which you would ask them to follow for bringing out clinically helpful teledermoscopy images?
It's an excellent question. I think for us, for our primary care physicians in Ireland, the difficulty is their caseload. And they may have 40, 50 patients in a session. And so the difficulty for them is, even though 20% of their case mix will have dermatology as a primary presenting complaint, there is really a very low knowledge base about dermoscopy among our primary care physicians, but that is building. So I think we're at the stage in Ireland, like a lot of the UK, our sister country, in that it's trying to provide a lot of basic dermatology courses for our primary care physician colleagues. And really, I suppose that would be the way. The first protocol would be ensuring that there is adequate training among our primary care physicians with the use of a dermatoscope. And then whether, I suppose, I really like to keep things really simple. So the 3-point algorithm and stuff like that. Yes, obviously you can use Dr. Menzies' protocols as well. But really for us, it's about trying to get high quality dermoscopy and getting training and awareness of dermoscopy, because even among our medical dermatology colleagues, dermoscopy wouldn't necessarily be utilized as a universal tool. And I think that's the same here in Ireland as it is in the UK as well. So it's to increase the level of awareness through increased training, and then to refer on. But unlike Dr. Nizar and Dr. Mulani, we haven't seen that there's been consistently high quality dermatoscopic and even macroscopic pictures coming from our primary care colleagues. And that's been a great issue. And that's why we, in order to standardize it, set up our own clinics. Now, I suppose we're dealing with a very small geographical country, where we can roll that out on a regional basis, and we can do that. So it's different to kind of a large country like America or India or Germany or somewhere like that. But I think standardization of the actual protocol of how the pictures are taken is the main issue for us. And then all of our pictures are obviously they're reviewed by a consultant dermatologist, who then they make the diagnosis and advice on management.
Right. So I think we have a question for you from the chat. So I think it's more of a comment, or I would say more question and a comment. So it says, from our experience has been that with dermoscopy, non-dermatologists, such as patients, forget to add some immersion fluid or at least moist the skin for good dermoscopy image. What about the rest of the panel? What do you guys think?
I think it's one of the things I mentioned in the talk, even, exactly that. People often don't, and then the xerotic nature of the surface skin change can actually obscure some of the pigmentary detail or vascular detail. And also then a very common thing certainly coming to our clinics is that, let's say the patient, he or she may be wearing some cosmetics, and so that obscures the detail as well. So absolutely, you need a clean surface as well as some lubrication to enhance and optimize the what we found.
So in my clinic practice, what I do is I have these alcohol pads in my pocket. So every time I take a dermoscopy image, either for education of my residents or my patients, what I do is I wipe the lesion with the alcohol pad, and then kind of start off with that contact dermatoscopy, which would be non-polarized, then switch it on to non-polarized, and then I do a non-contact polarized. So all the three modes are captured at the same time. So I do use a alcohol pad. And if I'm doing nail, sometimes I use Purell gel as a fluid. In the teledermatology practice, I always teach my nurses who are the LPNs who take our dermoscopy images or the teledermatology from the PCP site. They're all trained to do this, and they use alcohol pad before they take alcohol wipes before they take a good dermoscopy images. The only issue is sometimes patients do complain that there is a little sting and a burn when there is micro ulcerations and ulcerations on the lesion, but otherwise they are okay with when we say that this is why we are doing it. Excellent.
How do you handle? I'm sorry. I was going to say, how do you handle the infection issue when you have a wound that's open?
So I think we follow the protocol which was the manufacturer provided. So that's pretty much it. After and before use, we kind of clean it with alcohol pads, and that's probably what we do and what we recommend for our nurses who take these photographs.
And I would like to add to that, even with confocal, like as I've shown in my talks and in my practice, we always wipe the area very nicely with the alcohol pad. And obviously there's an issue of cosmetics and moisturizers. So that's my first lecture to the technician. If you don't have a clean surface, you will not get good images. And also the attachment is an issue of the device. So that's critical for good images. I do second that thing, yeah.
Right. So the next question is from Madam President. This is to Nisar. We find GPs and the nurses take great contact dermoscopy pictures using a fixed focus, inexpensive polarized dermatoscope. Not so good with expensive ones due to poor focus using retractable contact plate or lack of fluid using the unrecognized unpolarized mode. Any comments?
Yes, absolutely. Just to let you know that in the study that I was doing about 3 years ago, that I stopped, basically the device that the GPs were using didn't have a focusing element in it, and that simplified a lot of the problems. I used the Dermlite GL, which has a fixed focus distance, and you can put a little spacer in front of it. That's fine. So I used that instead of using a complicated one. And they could use the GL for other things like looking at other lesions and other things, oral cancer, etc. So yes, you're absolutely right. Use the simplest device that will work, and that has fixed, focusing, so that's not an issue. Yes.
Thank you, Nisar. Finally, Manu. So this is what I had this question for. The question was like, how do you create a successful teleconfocal practice?
Yes, so as I said, and as I showed in my talk, there are two ways people are doing it. One is the store and forward method. That's the standard way people are doing. But I think the key, either you use to, at least for the store and store and forward method, you really need to train your technicians to take good quality images and to take images at the right layers, at least to begin with. And that's the standard practice where everything will start for the store and forward method, because even with dermoscopy, you need to have good quality images. And if you don't have, then it is a problem. With live interactive, it's a different story because the expert is right there with you while you're taking images. So the expert will guide the technician where to take good quality images, how to take good quality images. So a standard can follow, but I think for live interactive, it's very critical to have a workflow between the practitioner who's scheduling the patient. So A, to schedule the patient, B, to have a good workflow between the clinician and the confocal expert, so they are in good sync during the time of bedside teleconfocal diagnosis. Did I answer your question correctly?
Yeah. So for somebody who wants to start off, teleconfocal practice. So you would recommend that they reach out to the experts, which are far and few in the world, before they start, or are there some kind of workflow which you would recommend for these kind of naive non-starters of teleconfocal practice?
Yeah, so I would recommend, based on my experience, I would say if the dermatologist is keen to learn, then I think start with live interactive, because that's the best way, at least 3-4 months. And also it's a best practice if you're new, you will get your technician trained very well. And after that, you can switch to the store and forward method, where you want a secondary consultation, and now you're pretty confident, but you're still not an expert, but you can occasionally send some cases, and that you don't have to rely. So I would say anybody starting confocal, I think live interactive is a good way to go forward, at least for 6 months. And when you feel a little bit confident that your technician can take now good images, you can identify some good features, now you can switch to the store and forward method. That would be my advice. And it's still to be tested, and that's what we are testing currently.
Excellent, excellent. So I think that I'm looking at the moderator console. So I think that's it for our session. Those were the questions. I really thank Dr. Barry, Dr. Mulani, Dr. Jain for joining for this awesome imaging session. Hope everybody finds it more useful. And if there are more questions, please send it across. With that, I'm going to give it to Dr. Pauly. Dr. Pauly, are you there?
Yes, I am.
Thanks.
Yes. Okay. Bye, guys.
Hi.
Excellent session, guys.
You guys
Thank
have
you.
a fantastic session.
Bye.
Bye.